Honorable dignitaries, esteemed faculty, and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on behalf of the entire team at Emcure Pharmaceuticals. We at Emcure are proud to present No Thrombosis Live Inbox, our highly acknowledged scientific program dedicated to exploring the multifaceted landscape of interventional cardiology. This program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of those affected with the cardiac diseases. I take this opportunity to extend a warm welcome to our respected course director, Dr. M.S. Hiramat sir. Sir is director at Cath Lab, Ruby Hall, Pune. CSI 2017, Program Chair, CSI Conference 2016, Convener, National Interventional Council of India, CSI 2004 to 2006. He has proctored many interventional cardiologists across the globe. Experience in peripheral angioplasty, including legs, iliac, and carotids. He has participated in some groundbreaking clinical trials. Thank you, sir, for your continued commitment and guidance to us for running this program regularly. Your expertise and fan following has made this program a resounding success. Our distinguished moderators, Dr. V. Mukesh Rao sir and Dr. Panchanan Sahu sir, are poised to share their knowledge, insights, and practical wisdom to empower us in the fight against the global health challenge of cardiac diseases. It is an honor for me to introduce our distinguished moderators for today. Dr. V. Mukesh Rao sir is Senior Consultant Interventional Cardiologist at Gleneagles Global Hospital, Hyderabad. He has over 21 years of experience in the field of cardiology. He is recipient of T.N. Raman Memorial Gold Medal during MD. He has performed live cases on FRR at a workshop in collaboration with Cleveland Clinic. He is an esteemed member of various organizations, former Associate Professor of Cardiology in SVMIS Tirupati. He is Vice President and Honorary Secretary, CSI Telangana and National Faculty, CSI NIC. Thank you for joining today's program, sir. Our another moderator, Dr. Panchanan Sahu sir, is Professor at Department of Cardiology in Kalinga Institute of Medical Sciences, Bhubaneswar. He has been in practice since 1983. He regularly organizes academic meets and conferences. Thank you, sir, for joining today's program. I would also like to introduce and extend a warm welcome to our esteemed speaker for today, Dr. Vishal Sharma, sir. Sir is Associate Professor in the Department of Cardiology at UN Mehta Institute of Cardiology and Research Center, Ahmedabad. He is Associate Fellow of ESC, winner of National TYSA Award, and he has published articles in various national and international journals. Thank you, sir, for accepting our invitation to present the case. And finally, I would like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me brief you all on the meeting agenda for today. We'll kickstart the program with the opening remarks and context setting from our course director, Dr. Hiramat sir. The meeting will proceed further with the case presentation on puncture and go case of RCA CTO by Dr. Vishal Sharma sir. Following this, we'll have a discussion on the case where all the faculty members will participate. Second case was supposed to be presented by Dr. Prem Krishna sir, but due to some exigency, he wouldn't join today. Dr. Hiramat sir has agreed to our request to present one of his own case today. It will be followed by discussion among the faculty members. Post the discussion of second case, we'll have the concluding remarks by our esteemed course director. I request audience to post their questions in comment box so that we can take up those few questions at the end. So without further ado, let's embark on this educational voyage together as we endeavor to enhance our understanding of interventional cardiology. I request Dr. M.S. Hiramat sir to share his opening remarks for today's program. Over to you, sir. Okay, we can start directly with the case presentation by Dr. Vishal Sharma, sir. Over to you, sir.
Thank you. Thank you for the kind introduction. And it is a pleasure to present the case among the esteemed faculty. So I'll just share my screen. Fine. It's fine.
Yes, we can see.
So this is an interesting case of RCCQ. I'll see what the case was. So this was a 54-year-old hypertensive dysrhythmic male. He presented to us with, ongoing chest pain. He had chest pain on rest and even mild physical activity. Some mild LV dysfunction. Angio was done at a different center. It showed single vessel disease in the form of RCCQ. This was attempted there, but they couldn't negotiate the lesion, and he was referred here for further management.
Sir, you are not audible.
Audible.
I think he's on mute.
Nothing audible.
Yeah, we lost his connection, I think.
Hello? Hello? Dr. Rishikesh, you have to unmute yourself.
reduce the amount of false lumen that you create by making a knuckle. And in this case, we were really successful in crossing from the subintimal space to the true lumen by just gently manipulating and rotating the hydrophilic filter extruder. So once this was done, we extended the microcatheter to the distal lumen of RCA. We exchanged the filter XTR wire with workhorse BMW wire, prepared the lesion with gradual, balloon escalation with 1 followed by 1.5 and then 220 semi-compliant balloon. Finally, we, especially in PTO cases, we always take the help of fiber because most of the distal vessels are always underfilled. There's always a problem in sizing of the vessel. Also, it's better to confirm always that you are in the true lumen distally. There have been cases when, wire this subintimal space is so huge that it feels as if the wire is in the true lumen and people have ultimately landed their stents in the process. So I was confirmed the true lumen. Also, it showed that there is some calcium in the mid part and also at the ostium, which was very tight. So we further took a cutting balloon to prepare the lesion in the mid part and especially at the ostia so that the stent expands well. I was also gave just a good idea about the size of the vessel, which was reaching up to 4 in the proximal part. So then we took 2 stents. The distal part was stented with 3/438 stent, and in the mid part we took a 4/34 stent. And then we expanded the mid and the distal part with the 3.512 NC, and in the proximal we took a 4.0 NC, and followed by a 4.5 NC, in fact, in the ostroproximal part. So this is how, IVUS really helped us in choosing the proper size of the stent and, achieving a final stent area, which is properly opposed, in fact, and properly expanded. So this was the final result, quite gratifying. The ostium was showing slight under expansion, as you can see in the end result. But we tried hard with a 4.512 NC, and this was the maximum. We went up to pressures of 18 and 20, 22, but this was the final that we could achieve. So we didn't try very hard in order to really perf, and this was the result we achieved in the end. So just to summarize, we use this puncture and bow technique, which is just a modification, or you can say an extension of stack and bow technique, in which you puncture the proximal cap with a harder wire, like a Gaia second or Hornet, a harder wire. And after entering the subintimal space, you just extend your microcatheter into that space. Followed by this, you take, any hydrophilic wire for that matter, like filter XT, very commonly used, or pilot 50 you can use. You can either do 2 things at this moment. You can make a knuckle of this wire, push it hard, and make a big subintimal space, finally re-enter distally, or at that moment you can just try some gentle rotation and mild pressure, and probably from a smaller subintimal space created by the puncture, you can directly enter the true lumen, thereby avoiding a large subintimal space and false lumen. This is the technique what we use in this step, just a modification of scratch and pull technique, and this is how we successfully handle this case. Thank you for patience. Thank you.
Dr. Vishal, which balloon you post-dilated proximal part?
Proximally, sir, we dilated with a 4.512 NC balloon.
I think distal RCA was some disease. It was showing some 50% narrowing. The distal part of RCA.
Yes, sir. The distal part of the RCA showed mild disease, but we could see that I think the plague burden was not much. It was like 30%. So we just let it go.
So the final result was yes, this is some 50% disease.
So 30-40% is on the IVUS, but we thought that would be too much of time because the ostium of the they were dual PDA sort of thing, so that ostium was also diseased. We tried avoided stenting across that lesion, so that we don't end up too many stones or closing that branch.
Vishal, your IVL, sorry, your IVOS was showing some calcification
Yeah,
more than 50% and circling.
yeah, yeah. Luckily, sir, we did a cutting balloon. It was mostly a 3O cutting balloon, and balloon expanded well, and thereafter the stent also expanded well in the mid part.
Expanded.
So that's why we didn't do much. I mean, we had an option of IVL with us, but the patients here have to think of the cost constraints also. So yes, IVL was there, but cost was an issue. We tried cutting it.
Yeah. The stent expanded well. That is.
Excellent case, Dr. Vishal. I just have a question. Which is the collateral which you wanted to do in case you wanted to go retrograde, and which is the donor vessel? I could not see properly on the angio.
Actually,
Just
sir,
for the discussion sake, I'm asking. I know you have done a wonderful job doing the antegrade. In case,
sure, so the
yeah.
collaterals were sparse, yeah. I think we were expecting that if that fails, we'll just try septal surfing because they were not what good collateral. Some epicardial and septals seemed as if going in the period, but not very good. So that's why the plan was if that fails, the integrate thing, because we were expecting tortuosity in the proximal.
Not so a very good case to do retrograde, probably.
Yeah,
you have done a wonderful job doing an integrating. And then just for the benefit of the discussion, how do you know that you are in the subintimal space, and how you came out into the true lumen? Can you just share the details, technical points? Yeah.
So we can just see this. You can see clearly the buckling of the wire. Dia-second was not moving forward a bit. And there was buckling in the. You can exactly see at the entrance of the cap. You can see the wire getting dented. So that was giving us a hint that we are in the subintimal space. Then what we did was brought the filter, the hydrophilic wire initially always went into the branch which was present at the cap. What we did was we just put the microcatheter across the proximal cap, and thereafter we took a filter XT. Now there were, as I said, there were two options to make a knuckle and just push it. But what we did was we tried a little vigorous rotation. Although I understand that this is not always successful, but we have tried in a few cases, and what we have seen is there are chances, especially when the total length is less than 20 mm. There are chances that you catch some of the microchannel within the plaque or just enter into the true lumen, and this is what we did in this case.
So with the vigorous rotation of the microcatheter, you could
not the microcatheter, the wire we rotated it. Not very vigorously.
The wire, the tip of the microcatheter, you have rotated. Then you could enter into the true lumen.
We could enter the true.
Wonderful. Okay.
Sir, you are not audible. Can you a bit louder? Dr. Sahu, sir.
Dr. Sahu, can you increase the volume of your laptop?
So, is there any other case, or should I show my case?
Yes, I request you to share your case. We are really looking forward to it, sir.
Okay. So this is a 59-year-old female, hypothyroid, and she's not diabetic and no past history of an AMI. Progressive dyspnea over last 1 month, and then ultimately admitted with heart failure, with bilateral craps, etc. This is the right angiogram. The left was getting retrograde from the right, and you can see there is a spontaneous dissection beginning from the mouth. One might even wonder why this is not catheter induced, because we have used JR and then probably changed to a different kind of catheter. But you can also see collaterals going to the LAD. You can see the LAD filling up in later frames. So spontaneous dissection, and we thought we'll image from inside. And this is another picture of the right, and collaterals plentiful to the LAD. So LAD, of course, is expected to be a deceased vessel, but probably a long segment disease or additional second lesion somewhere here, because it's not filling up proximal to this portion. So the angiogram appears like a spontaneous dissection or a fragmented thrombus. Now we have to decide whether there is a critical underlying lesion or no. Do we need to intervene, and how to confirm wire is in the correct lumen, and what should be the stent length? All these questions we thought would be answered once we do imaging from within, and that's why we had the right coronary wired, and we thought we'd take the 2 mm balloon, but it was not crossing. It was quite surprising. I mean, the vessel was not critically narrowed, but this can happen if there is a spontaneous dissection and if your wire has gone into the lumen, which is not the correct lumen. So we were a little bit skeptic, and we wanted to see it from inside. So we tried bringing in an OCT catheter. Even that did not cross. So one must understand that if a small 2 millimeter balloon is not crossing, there is no great wisdom in trying to put an OCT catheter. You could have put an IVUS catheter, which is much, much thinner. But as I said, OCT was not crossing, and hence IVUS was done. This catheter, you can see, is passing quite easily. Some of the IVUS is not running. One is possible to make it run. So this was the extent of the spontaneous dissection, starting a little distance from the mouth of the right, and ending somewhere here. Beyond this, the vessel looks quite normal, and the distal vessels are flowing quite well. So after doing some balloon dilatation, we're able to get an OCT in. And what OCT shows is from this point at 20 marker, going back, you can see a dissection plane. So luckily the wire has gone through the correct lumen, and the dissection plane extends backwards almost to the ostium. Now, these additional informations are very strongly demonstrated on OCT. You can sort of imagine on angio that we could be expecting a dissection, a spontaneous dissection. After this, the OCT catheter was advanced after pre-dilatation balloon. This is just to confirm the diagnosis as well as the length of the stents. So you can sort of check where the dissection begins, where it ends, and go obviously a few millimeters beyond that dissection. So this stent placement is based more on the OCT assessment, and this is how the stent is placed. We were quite sure, since we had done the OCT, that we are in the true lumen and not in the false lumen. Keep watching the lower frames, and beyond 20, you can see a false lumen. In fact, there are multiple small lumens. A fragmented thrombus is very difficult to differentiate from this. Whatever, I think the true lumen is clearly narrowed because of the spontaneous dissection. And these were the multiple cuts that we are seeing. This is the lumen through which the OCT imaging catheter has gone, and you could see the false, multiple cracks and another false lumen, big lumen, of course. And this is how the blood was going, and patient was not very symptomatic. On longitudinal axis, you can see the beginning of the end of the dissection, and the beginning is far more proximal. So the pre-dilatation was done, then the stent was positioned, and this is the final result.
On the image.
So you can see on this final images that the dye is flowing well into the distality of the vessels. So one true lumen is clearly increased, and you can see the flow going. So this is how we ended. I will show you another case of spontaneous dissection. As we know, the spontaneous dissections are very common in females. This is another lady had an anterior MI. She's only 47-year-old, and she presented to another hospital with this ECG. So this was a clear-cut anterior wall infarction, and she was taken to the cath lab, and this is what the operator found. Yes. One more thing. थोड़ी देर के बाद So this was the LAD, and clearly the proximal LAD is much thinner than the mid and distal LAD. So the operator felt there is no critical lesion and we could leave it as it is. This was in another hospital, and so no intervention was done to this. Patient was on coronary dilators, anticoagulated, in CCU as well as on discharge oral anticoagulation. And that is how patient went home. But clearly you can see proximal LAD showing some degree of narrowing. And are you people able to appreciate that there is a very strong suspicion about spontaneous LAD dissection in this particular picture, and this is extending into the D2. That's why the suspicion becomes stronger. You can see D2 dissected up to this point, and subsequent lumen looks quite good. So dissection starting in the osseal portion of LAD is extending a significant length, and also taking dissection into the proximal, fairly long segment of D2. So the anterior MI was the first one. The inferior MI happened 1 month later. Now this is the right coronary artery during the anterior MI, and it looks dominant and it's quite normal. This is how she presented 1 month later. So 1 month later, she has an inferior MI and was again taken to cath lab. And that's the time the right coronary artery shows a long segment critical narrowing. So mind you, this is only 1 month gap. The previous 1 month before this was the right coronary artery. And now this is the right coronary artery, and patient has come with an inferior wall. For inferior infarct, this was considered to be the culprit vessel, which is absolutely justified. And this was the difference, 1 month apart. This is during anterior MI, and this is during inferior MI. So there is just 1 month gap between these two. So obviously this is not atherosclerosis, but spontaneous dissection. So thrombus aspiration was done, and the flows clearly improved. After thrombus aspiration, you could see the distality of the right coronary artery getting filled. And stent were placed, not the entire length, but a sizable length of stent was placed. The family was in panic because a 47-year-old lady, no risk factors at all, thinly built, used to take regular exercises, no risk factors, and has 2 infarcts, one anterior, one inferior, back to back in 1 month's time. And this is how the right coronary was fixed, the other hospital. But you can still see some kind of dissection planes in the distality of right coronary artery, which were not addressed. Obviously, you can't go on putting long and further long stent. That's how the operator left this patient. Patient was again anticoagulated orally on discharge, and patient was then with us. You can see the dissection planes in the distality of the right extending into the PD portion. This is how it is. And so this is right artery at the time of anterior MI in October 3010, and this is 1 month later, 2811. So this is not atherosclerosis, but obviously even from an angiogram, you would guess that this is a spontaneous dissection. We of course had a imaging from within, which sort of confirmed that there was a dissection. What was worrying is at the time of the second infarct, I mean, as we said, this was the time of anterior infarct. This is the time of inferior infarct, 1 month apart. And you could see the LAD during the time of inferior infarct, 1 month after it was left unaddressed. I mean, it's threatening to close again. The dissection is bigger than what it was during the anterior MI, and thus it appears to be worsened. You can see in the still frames on this side the true lumen and the false lumen. And I would feel the diagonal was very important in confirming or strongly suggesting the diagnosis of spontaneous dissection. You can see the LAD dissection extending into proximal portion of the D2, and that's why the proximal segment is showing a thinnish contrast flow, and the distal part of the diagonal 2 was looking quite nice. This was another opinion we got from Mumbai. And Dr. Dalal also felt that this is not due to atherosclerotic disease. And he felt that LED looks like dissection, and there would be a danger of another anterior wall infarct if things are left unaddressed. So something should be done. We got this patient in our cath lab. Patient was stable, but the family was extremely worried because of two MIs back to back in different territories. And I mean, the dissection was quite apparent here. I mean, the stent was placed only in this much portion in another hospital, but the dissection beyond that was left unaddressed because flows were generally well preserved. The ECG, of course, had stabilized. R waves were coming up in anterior leads. Inferior infarct is obvious on the ECG. So this is how we started the case in our cath lab in Ruby Hall. And you can see a dangerous looking dissection in the proximal portion of the LAD. What was important is how will you address this? I mean, you can see here, this was the time of anterior MI. This is the LAD at the time of inferior MI, and there is only 1 month gap between these two. And you can see a rapidly growing false lumen on this side, and true lumen is on this side. And you can see the D2 showing a thin dissected segment in the proximal portion and undissected distal portion here. So a decision to stent was made. So we have to make sure that you're in the correct lumen, the wire, and then you're going to stent, and where you're going to end the stent, that is also important in this case. So we decided we will stop just at the mouth of the diagonal so that flows, though they were going through the dissected segment, would be preserved. So you can see the dissection extending into D2 here. And this was some other case, but a similar looking case. So these are the possibilities that come to your mind and my mind, whether this right is showing a spontaneous dissection or an organized fragmented thrombus. The underlying lesion is a little bit uncertain, so we need to image from within. And this is back to our case, and you can see somewhere here the dissection starts, and this is the dissected segment. So you have to be a little bit careful, but most of the time you would get into the correct lumen, and you can see a false lumen on the other side. So once you are certain, and you had these images where the wire and the OCT catheter is in the correct lumen, and then you have dissected planes in the other side, on the other side. I mean, unless you image from within, you would probably struggle to make a strong decision. But since we had imaged this, many people like to call it lotus root appearance, which is a very true description. Like you have one true lumen and others are false lumens. And this is after putting a long stent. You have very good flows. Most of the time, take a stent which would go a few millimeters on either side of the dissection. I think stent length has to be a little bit more liberal whenever you have spontaneous dissection. Also, you need to make very certain that you're in the correct lumen, and this is very easy once you image from within with an OCT. So this is how it was when we started. The patient actually had a lesion in the LAD, which was fresh. This was probably an old dissection, but patient has not been troubled by this dissection. And after stenting, you can see a very good flow and very good distal vessel opacity. So spontaneous coronary artery dissection is a possibility, especially in thinnish female. Looking back, this lady showed some marphonoid features like the span and length of the hands were very suggestive of Marfan's picture. So this is how we did the case actually. It was very important to go through the correct lumen, and we knew that the true lumen was on the left of the screen, and we were able to take the wire through that. Then, of course, image. I think in these kind of cases, unless you image, you will be very uncertain whether you are in the correct lumen or no, and you would probably be hesitant to put a stent. So in this case, imaging was crucially important, and you could see the true lumen and the false lumen on an OCT. And you can see in some areas, the true lumen is smaller than the false lumen. And then how much to stent was also an issue, because if we have got the stent beyond D2, probably the flows to D2 would seal. So we had to end the stent just at the beginning of D2 here, and back end at the beginning of the LAD. So based on OCT, we wanted to perfect the stent, sort of stent to be pushed on the sides into the lumen, into the vessel wall. And that's why we first put a wire in D2, and then the stent placement. So stent is ending in D2. I think the opacity of the wire is also helping us to decide where the stent should stop. The back end is, of course, at the mouth of the LAD and beginning of circumflex. So this was dilated with 4x10 compliant balloon, non-compliant balloon actually. And yes, of course, we have to image again. I think what is correct about this position is the flows to D2 are very well preserved. So the stent is ending just at the beginning of D2, and that is how the flows are preserved. When we did an OCT again, we could, however, see that this portion was post-dilated, and there the stent is well opposed to the wall. However, the portion of the stent between D2 and D1 was not dilated because we didn't want to lose flows into D2. And that's why this stent looked not very well opposed. You can see a gap between the intima and the rest of the thickness of LAD. So we had to come in with another balloon and stretch this portion. And then again, we did an OCT, and you could see this gap is neutralized. This was before and after doing a balloon dilatation with a foro balloon. You could see no gaps between the intima and the remaining vessel. The stent is well opposed, and you can see that on the OCT imaging. So OCT thus proves extremely useful in this case. So this is how we started a rapidly progressing dissection. This is how we ended stent right here, and you can see some kind of contrast in the proximal portion of the diagonal. But diagonal flows were well preserved. There was a dissection, but we didn't feel like addressing this. It would have been pretty challenging, wisdom-wise, to put another stent in the true lumen of the diagonal too. So this is the right coronary artery. In 10th month, it was looking quite good, but on the 11th month, it gave an inferior infarct, and a PAMI was done. And this was the LAD dissection, which brought this patient first time with an anterior infarct. At the time of an inferior infarct, the dissection seems to be worse than at the time of anterior infarct. So 1 month, the dissection is still growing. And once we put the stent, everything is very well sealed. So this was a thinnish marfanoid lady, and she had the dissection. So you could see the stent starting from the mouth of LAD, ending at the mouth of diagonal. Diagonal flows were preserved, though the dissection was not corrected. The right coronary was stented in some other hospital, and only this much was stented. The dissection was not addressed in the distality of the right coronary artery, but flows through the true lumen were quite good, both going into PD and PLV. It's about more than a year, and this patient continues to do very well. So all ACS are not atherosclerotic, especially in young female with no risk factors. Spontaneous dissection is unusual. I'm sure even in my story, this is a very, very rare happening, and especially in this case where once it is LAD and soon after that it is RCA. Imaging, especially with OCT, is extremely useful, as we saw. This is in making the diagnosis, be sure that you are in the correct lumen. It can also give you a stent length and whether it is well opposed or no, and status of the side branches. I will end here. We could all take some questions or any comments. which anybody wants to make.
Sir,
Yes, Dr. Sao.
congratulations, Dr. Hiramat sir. The two cases like presenting with the antral MI, spontaneous dissection, and after 28 days only, he has presented with the inferior MI. Two things I want to ask: how you size the stent, how you take the stent sizing, and second thing, how to prevent the second spontaneous dissection occurred only 28 days after. So, what strategy can prevent the
Oh, this is a very important question. Like she dissected in the LAD and then in the right within 1 month. And we knew when we saw the angio during anterior wall infarction that the right looked perfectly normal. Yet it dissected in a very short time. There is no certain way, but I guess a good dose of statin, calcium would probably help us to make the dissection a little bit less possible. But I'm sure we don't have a true answer.
there is no way to prevent dissection in the future once we find a dissection.
Yeah, I mean, she could end up with aortic dissection.
What should the treatment strategy?
Dissection of the brain arteries and so on.
Yeah, that risk is there.
Yeah, absolutely. That remains.
Good evening,
Thank
sir.
you, sir.
Good evening, sir. I am Dr. Mukesh. Excellent demonstration, sir. Excellent presentation. I have a small question, sir. Now, a lot of labs are coming in peripheral centers where we don't have availability of imaging immediate. So, any tips and tricks? If we cross with a wire and the balloon goes smoothly, can we go ahead and stent? Or if there is balloon non-crossable lesion, then we defer the procedure and do an imaging. Can you just give some tips and tricks for the benefit of youngsters and resource limited situations?
Yes, I think it is very true, but I believe they have started having portable IVUS and portable OCTs, so you can make a request. Like you do an angiogram, then when you want to do an angioplasty, get the OCT or IVUS just for that particular day, and you could have imaging from inside. However, as you said, if it is just not possible to image from within, then you have to mark your ends, where the stent would end, where it would start, and be very precise, very accurate, and sort of don't use very high pressure. Use the bigger diameter stent and deploy it at slightly low pressure. Generally avoid post-dilatation.
And then is it enough if we stent the initial part and then if the flow is good and leave it the distal, or put a long stent?
In our case, the operator in the previous lab had just done the same thing as you're saying in the right coronary. He put a limited length of stent, accepted dissection in the distal part of the right coronary artery. On the left side also, we accepted dissection in the diagonal and stented the LAD, which was looking worse in 1 month's time. So, I mean, making a diagnosis of spontaneous dissection, putting them on anticoagulation, etc., is a reasonable option, but at the same time, you must have repeat follow-up. In this particular case, I don't think the patient would have come otherwise. I mean, she got an angio done on the LAD, within 1 month, again, another angio, only because she had a right infarct. So in a way, she was lucky that the LAD dissection and progression of the dissection could be seen with open eyes and could be stented before she gets another anterior one.
In your first case where you presented you could not cross with a balloon. If in case we could cross with a balloon, so we can go ahead and stent or still prefer an imaging, sir. Imaging always gives a better information, but in case we don't have it, can we go ahead and stent it with confidence?
Yes, yes, I think so. Yes, absolutely.
Okay, sir. Thank you, sir.
Any other questions, comments from our moderators?
So OCT imaging is essential, I think, in treatment of these spontaneous dissections to know the extent of the dissection and sizing of the stent and getting a good result of stenting.
We have all been doing angioplasties without something like OCT or IVUS for donkey's years. I mean, as things become available, our angioplasty techniques are getting more sophisticated, more precise, more accurate, and probably more beneficial to the patient. So I think especially the OCT or IVUS on higher, I feel it's a good strategy, like any small cath lab in a small town or village. They can borrow the imaging machine for a day and have the imaging from within.
Only issue is the cost, sir. With a lot of government schemes, at least in our state, and then with dicey situation.
No, I mean, I'm not denying such thing. It's not that we do imaging on every case where it is necessary. So these, but then in India, reuse is another easy option. So those who own the labs, like in a small town, I know some people owning the cath labs. I
Yes,
think
sir.
they can definitely
take imaging also along with.
yes, yes.
So
Okay.
it's a indeed.
The end.
Yes, sir. So it's a indeed treat for audience today because 3 cases were discussed in today's program and 2 were presented by our respected course director. Sir, any concluding remarks before we close from your side? Hiremat, sir.
I mean, spontaneous dissection is a rare happening, but where you don't see any risk factors, like this lady is thinly built. She has had 2 pregnancies, no hypertension during pregnancy, and she has LDL, HDL ratio is probably close to 1:1. It is that good, the LDL, HDL ratio, and yet she had a spontaneous dissection. So this is something which is not atherosclerotic. I mean, you have to sort of keep your wings open to think why such a young lady who had no risk factors got an infarct and what should be the most appropriate treatment. And that is how I would feel one should think. I mean, her LDL was something like 55 with an HDL of 45. So, generally speaking, we would not imagine that a young female would get an infarct with this kind of lipids. So, imaging becomes very, very important in these kind of cases.
Yes. So we are nearly at the finish line. But before we conclude, let's express our gratitude to all who made this scientific program possible. I extend my deepest gratitude to our respected course director, Dr. M.S. Hiramat sir, for the guidance, expert comments, and interesting two case presentations today. So thank you, sir, for leading from the front. I would like to express my sincere gratitude to our distinguished moderators, Dr. V. Mukesh Rao sir and Dr. Panchanan Sahu sir, for sharing their knowledge and expertise with us today. I would also like to thank Dr. Vishal Sharma sir for his insightful presentation. I would also like to thank our esteemed audience for their time, continued love, and support for No Thrombosis program. On behalf of Emcure, I extend my heartfelt thanks to everyone from sales, marketing, and medical team at Emcure who have contributed to this program's success. So let's carry this knowledge into our practices, research, advocacy, and fostering a healthier future for those with cardiac diseases. Thank you once again for attending and encouraging us. Good night and good time ahead.
Rishikesh, how many were attending this session today?
I'll just take up the number and let you know, sir.